So why do we want patient and public involvement in research? It's very simple. If patients and the public don't tell doctors what they want, they won't get it. So we know that research is important for patient care. We want to prioritise the most important research. The decisions about what research is important really should, front and centre, take account of what patients want. And all of us are going to be patients one day, and I hope my voice will be listened to in that respect as well. Next slide, please. So we got some money from Care for Brittle Bones to do a study that actually was in two parts. The first was the validation of the paediatric OI quality of life tool that Claire Hill had developed. And the second was to look at patient priorities for research. And within that second element, which is the thing I'm going to talk about, that there was an assessment of the willingness of patients to participate in research. What would you be prepared to do to take part in research? And originally it was focused on children, but we then developed it into a broader study that encompassed adult priorities as well. Next slide, please. We looked at the adults and the children separately, though. We didn't want one group influencing the other directly. There was the opportunity for some free discussion within the focus groups that we carried on, and some specifically directed questions, because that was mostly in the area where we were trying to work out, well, what would people be prepared to do? And we had to give specific examples, and we gave the same examples in each of the focus groups. Next slide, please. So 8 different centres in across a range of European countries, and then also in Russia, Chile and Hong Kong, were invited to participate. We set criteria for that participation with a target group number for each of the focus groups, whether they were adults or for children, between 6 and 8 participants. Before each of the groups was held, Claire had a teleconference with the focus group leads in order to ensure a consistent approach. And each country had to take the protocol through their own national research governance and ethics process. So it was all signed off, all properly approved. Next slide, please. Each of the focus groups met for between an hour and an hour and a half, and this was pre-COVID, so it was all done face-to-face. Each of the focus groups was led by an expert centre member from a local OI centre, and the specific questions that we asked were, what are the most important research outcomes that you want to see, and what would you be willing to do? And using stickers and post-it notes, the ideas were captured on flip charts and then rated, so that people actually said, well, this is the one, you know, that might be an interesting idea, but we want to rate it, and we want to sort of say that one is more important than that one. Next slide, please. So for the children, we actually had 25 different distinct suggestions being made. Rather than show you all 25, I've grouped them into similar areas, and I've chosen those areas really because they also fit for the adults. So it allows us to do a bit of comparison between what the children and what the adults said. And so in those areas, there are the bone-specific things, like I would like to see research into fewer fractures, or non-union, or something else. Other body systems, whatever they were, muscle, lungs, heart, whatever. Interventions that were directed at bone and muscle. So not things, say, like non-union, but things that would be specific for increasing bone strength, a drug or something like that. Then things relating to lifestyle and general health. Then things relating to testing, and that might be questionnaires, but it might be blood tests or urine tests or bone density studies or whatever. And then things relating to the education of doctors and others, and also basic science research. And I kind of lumped those together. Right, next slide, please. So for children, by far and away the biggest group was in the interventions group. And essentially that meant new medicines or a cure. Okay, next slide, please. The assessments that children were willing to go through, and if you look at the scale at the bottom, it's from 0, nobody agrees, up to 100%. So the things that everyone was comfortable with were having height and weight done and having a DEXA done. And that's not really that surprising because that happens pretty much all the time anyway. X-rays and taking part in focus groups and doing questionnaires were pretty acceptable. Perhaps surprisingly, blood tests were more acceptable than a urine test. Children were also perfectly happy to be interviewed. Bone biopsy during surgery was as acceptable as giving a urine test, which I thought was remarkable. Skin biopsy was not very popular. Next slide, please. So if you were going to do interventions, a completely new procedure, as in a surgical procedure, probably came in lowest. Comparing a new procedure or a new drug with an existing treatment was the most popular. A study where you knew what the drug was also quite popular. A placebo-controlled trial, that is, getting a medicine or a blank pill with no activity and you didn't know which one you were going to get, only came in at just over 25%. So the strong message from that is that if we want to do studies, people aren't willing to give up the treatment they're currently receiving. They want to compare it with something else. Next slide, please. In the adults, there were a larger number of distinct suggestions made, and I've grouped them similarly to how we group them for the children. Some of the categories, the overarching categories, encapsulate larger numbers of different things, obviously because there are 40 different suggestions being made. And the total number of responses from the adults was greater overall than for the children, despite the fact there were similar numbers within the focus groups for adults and for children. Next slide, please. So in the adults, the largest priority group was around lifestyle. That is, things that would improve your day-to-day existence, rather than being keen on another new intervention. Testing was also thought to be important, but other body systems came up as the third most important area, with lungs and muscles being the most commonly mentioned things. Again, bone-specific interventions and basic health, basic science or health services research were down at the bottom. So in the adult group, you'll notice health services research is substituted in for education. So a slight difference there. Next slide, please. And again, with the assessments, there was general acceptability across most of the assessments, most of them acceptable for 80% or more. Interestingly, X-rays have dropped back a little bit there. People, I think, being concerned about the number of X-rays they may have had over the years. Nobody wanted a skin biopsy. Next slide, please. And in terms of interventions, nobody wanted a new procedure. The most popular was a comparator study, followed by open label, followed by placebo, as in the children, actually. You'll see that the scale at the bottom suggests that only about just over 30% of adult patients felt that even a comparator study was something that they would agree to participate in. Next slide, please. So just if we look at the comparison of the adults' responses and the children's responses, you can see the scales are the same, I should say. Children are more keen on interventions than anything else. They're less concerned perhaps about body systems and lifestyle, perhaps because the body systems are things that become more obvious to you as an issue as you get older. And the testing and the basic or health services or education, again, came down at the bottom end for both groups. Next slide, please. In terms of interventions, the children are clearly far more keen on participating in clinical trials than adults are. I think that's really important to remember when we are constructing trials going forwards. It's really important to listen to the views of the children as well as the parents in putting these things together. Next slide, please. In terms of why you would want to participate, from the point of view of the children, it comes down to trust, feeling supported, both by from their family, but also from patient groups and associations. Some degree of risk versus benefit, and actually the need for anonymity came up a couple of times as well. For adults, they wanted to be treated as a collaborative expert, that they were co-producing the work. There's a sense of altruism there, but also the thing that might stop them doing it is lack of time, lack of money, or the energy. Yeah. Okay, next. So we have identified a wide range of research priorities. Children are more focused on being cured, having new medicines, adults more on quality of life. And there were also some very clear influence of local context as well, by which I mean that in areas where you've got very poor health service provision, people are much more willing to experiment with new things. And that was clear from the focus group in the Russian focus group. Next slide, please. What about participation? There was a high, as I said, acceptance of the non-invasive sorts of testing, such as questionnaires and imaging and measurements. Bit more hesitancy around the more invasive tests. Next slide, please. Children being more willing to participate than adults in drug trials, I've already illustrated. But the clear preference is for a comparator study, even over an open label study. And the children really did want to have stronger bones. Next slide, please. So there are pros and cons to participation in studies, but the clear themes that came out from the participation element of the work was the need for trust, the risks versus the benefits, and the potential costs. Next slide, please. So I want to move on in the very few minutes I've got left, and I can see there's lots of questions, but I'm not sure I'm going to get to answer them all. I'll talk to you very briefly about a new medicine. Losartan is a medicine that's already in widespread use in both children and adults in the United Kingdom as a treatment for high blood pressure and the loss of protein in the urine. We're interested in it because it reduces the level of a chemical called transforming growth factor beta, TGFB, in the bloodstream. Next slide, please. Why are we interested in this? Because TGF-beta is overexpressed in OI, by which I mean if you measure TGF-beta in mice, which is what you can see here, the coloured lighting up mice have got severe OI, and the amount of TGF-beta they are reporting, that is, how active it is double what it would be in a mouse without OI, and that's shown in the graph on the right-hand side. Next slide, please. If you give an antibody to TGF-beta, the central picture there is of a severely affected mouse vertebral building block without treatment. On the right, with treatment with the antibody, very similar to what you see on the left-hand side, which is a so-called wild-type mouse. That is a mouse without OI. Next slide, please. We gave losartan to a mouse called an OIM mouse, and we got them to make a lot more bone as a result of giving it for 8 weeks. Next slide, please. What do we want to do next? Well, given the results of everything I've talked to you about already, what's clear to me is that we want to have direct involvement from folk with OI from start to finish in designing a study that will test whether losartan increases bone mass and strength in children. So we want to have help with designing the study, conducting the study, actually looking at the data that the study generates, and then communicating the results. And the first step is to gather together some focus groups on the design of the study. Next slide, please. So if you fancy that, if you want to help, if you'd like to be involved, the email address is right there, oi_losartan_study@sheffield.ac.uk. Send an email to that address, say that you're interested, and we'll get in contact with you.